Hello, and welcome to The Two View, the cutting edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Martha Roberts, and I'm a practicing ED nurse practitioner and professor in Northern California. I'm here with my fun for the summer friend, Michael Sharma. Hi,
I'm
Mike.
fun all year round, Martha. My name is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area and an adjunct professor of PA studies. And before we dive into our topic for this month, we have a one mega topic, honestly. I wanted to thank you for your kindness always, but specifically for your kindness this month. My wife's stepfather passed away quite unexpectedly last week, and our family has been having to do all the things you do with an unexpected death, and you've picked up my slack even more than you usually do, and for that I thank you.
Well, Mike, I'm really sorry. And unexpected and close family members, it's just so difficult. So happy to be here for you any way I possibly can. And also, this month, Mike, I think it's important that we sort of just kind of stuck to the one topic that we picked up, which was radiology, and we really felt like that segment. It was just so good that we're just sticking with radiology this month. But I'll explain that in just a moment. So sorry again for what you're going through. And this month, we still want to answer some burning questions. Burning questions I get on any shift, things that keep coming up. It appears that there's a difference of opinion on a lot of questions in EM. And that's fair because there are many ways to do a lot of what we do. But then again, sometimes there is only one way, as my great mentor and friend, Kristen Captain Reddington, would say, who's been an ED nurse for over 25 years. She's also a mom. And that phrase carries a lot of weight, in my opinion, right? There's only one way when you're a mom.
We talk about how, like, oh, we're just gonna talk about one thing today, but our conversations span the gamut from neurology to orthopedics to abdominal, not just trauma but infections. So as much as we talked about one thing, we really our one thing contains multitudes, as you or I do as well, Martha. When who better to introduce these multiple topics in one than our oblique view guest this month, Dr. Robert Bob Tubbs. He is leading our new CCME radiology course called Mastering Emergency Imaging with partner Dr. Adam Janicki. He's worked with for a long time, as he'll explain. It's a brand new, one of a kind, really intensive, image heavy, but also evidence and literature heavy, in depth course designed to strengthen your expertise in emergency imaging. And it's presented by two long running and distinguished, both inside and outside of the CCME faculty. And these are academic, practicing emergency physicians with a passion for teaching not just the basics of emergency medicine, but all the stuff that, even if you've been doing this for a while, you're going to pick up new things, the real ins and outs of emergency imaging. This course is tailored to you and I, to the people who are on the front lines in emergency medicine and urgent care. That's you as well, listening right now, the P or the NP who has to make these decisions with contrast, without contrast, with and without contrast. We get into all those things and more in this course. Mastering this ability to quickly choose the right imaging study and then interpreting these things independently, ooh, that's next level, is essential in the master emergency clinician. And that's what this course will allow you to become with diligent study.
Yeah, and we give you a little bit of a taste of that when we talk to Dr. Tubbs here in a moment. And we had originally recorded this with him, uh, thinking, okay, we'll just do a quick little segment three, and we'll talk about some of our other burning questions in segment one and two. But we've decided that we're going to save our other burning questions for next month, make this a two-part series, and let you listen to this burning hot segment of radiology with Dr. Tubbs. Let's just make this an all radiology hot topic for us to review with you guys. But the other interesting part about this is that, as Mike said, we talked about a lot of things. I even made, some notes here. But essentially, we talk about, is there a true allergy? What's a reaction? When are we really giving that contrast? It's just great. So I'm really excited to let Dr. Tubbs jump into this show now and start this conversation.
Let's jump right in.
All right, it's time for our final and most anticipated segment three, our oral contrast For our final segment, we're really going to stir some things up today. Let's first introduce our oblique view, Dr. Robert Bob Tubbs.
This is great. Dr. Tubbs graduated from the University of Massachusetts Medical School in 2002 and went on to complete residency training in emergency medicine at Brown Medical School in 2006, where he also served as chief resident. He has been an attending physician at Brown since then, working at a variety of clinical sites, including Rhode Island's only level 1 trauma and tertiary care hospital, Hasbro Children's Hospital, and Women and Infants Hospital. He served as assistant and then associate residency director for 12 years.
And during his time at Brown, he developed a novel and popular emergency radiology elective and rotation for EM residents, medical students, and APPs that has run for 18 years. He lectures frequently to the medical students and residents at the Alpert Medical School of Brown University on emergency radiology topics.
Love that the PAs and NPs are getting included in that goodness as well. He has been an invited speaker on emergency radiology topics at the American College of Emergency Physicians for several years running and has lectured nationally and internationally on emergency radiology topics, including different CME conferences, ground rounds at different hospitals, and national meetings, including the Radiological Society of North America and the American Röntgen Ray Society.
He's authored multiple CME and review articles on EM radiology subjects, as well as contributed to radiology images to textbooks, national lectures, and to the peer online testing program.
And as a result, he has received multiple national and local teaching awards, including the ASAP Junior Faculty and National Faculty Teaching Awards, as well as the Council of Residency Directors in Emergency Medicine, as known as CORD Academy, for Scholarship in Education Distinguished Educator Award. That could be the longest title of an award I've ever heard of, but well deserved, I'm sure.
If anybody's going to get it, it's going to come from a radiology sector to be that long, right? So I love that for you. So Bob, I'm so excited to see you. It's so great to hear from you. We've had a lot of boot camps in our history together, and your new course sounds great. So I'm already registered, right? Right in front.
Thank you guys so much for having me. I'm super excited to talk about, a subject that's very near and dear to my heart, and that's emergency radiology. So thank you guys for having me on the show. I can't wait.
So I know we mentioned in the beginning of the show a little bit about your course, but can you just tell us just a wee bit more about it and what you cover for the radiology course?
So this is really the culmination of about 20 years of work in this area. I've dedicated my whole academic career to emergency radiology. And I've been teaching a course for our residents and APPs for a long time now, and I really wanted to take it to the next level. So this was my sort of chance to do a deep dive into all things emergency radiology. And so it's covers mostly plain film and CT. I leave the ultrasound to the ultrasound gurus. There's plenty of them out there. And so I feel like people get a lot of exposure to ultrasound, but I feel like in terms of plain film and CT interpretation, there's really not a lot out there, especially for emergency providers. And so it was a need that I've seen over the years and something that I was really eager to jump in and try and fill. So it's pretty in-depth. It really runs the gamut from very basic to some pretty advanced pearls that I picked up over the last 20 years. It's mostly case-based, so it's pretty entertaining. I think, we had a lot of fun filming it. And I think it's pretty engaging. And like I said, there's a ton of great material in there. So we're pretty excited about it.
Hopefully you dig our radiology themed segment titles for our
I
podcast.
appreciated that. Yes.
Dry scan, and yeah, so we're now in the oral contrast section. So we're going deep dive into this. And speaking of contrast, we're going to start with contrast. We want to clear things up. CTs, MRIs, we order quote contrast, but of course contrast is not just contrast. You don't use the same stuff, in different imaging modalities. We want to talk about how do you make the decision about ordering CT, MRI with contrast, without contrast, why it's so important, and also touching on like what it means to give contrast. What should we anticipate? We want to be ahead of our patients to anticipate problems, right? So what should we anticipate, in risk situations where there are problems with contrast? So the first big question is, when should we order CT contrast specifically? What imaging modalities work best with contrast? What particular diagnoses are we trying to answer the question about when we order contrast? Are there broad themes, or are there any sort of, like second line things that maybe not even seasoned clinicians know about with ordering contrast?
So, starting with CT, it really sort of depends on the body part and specifically what we're looking at. So, we all sort of know for looking for intracranial hemorrhage, blood inside the head. Mostly, we're going to stick with non-contrast images. In broad terms, if we're worried about vascular phenomenon, we're going to need contrast. We're going to need intravenous contrast to help with that. And so if you sort of play that out, if someone comes in with acute stroke symptoms, we're going to be getting an IV contrast study of their vessels. If we're worried about, something like mesenteric ischemia, we're going to want IV contrast to look at the abdomen and the abdominal vessels. If we're worried about aortic dissection, pulmonary embolism, those are sort of obvious. What may not be as obvious, things like trauma. If you're worried about solid organ injury, you absolutely need contrast on board. You cannot adequately evaluate for solid organ trauma without IV contrast. I had a case, I don't know, about 10 years ago, an 18-year-old kid was running from the cops. He fell off a 10-foot fence and went to one of our small community hospitals with abdominal pain. And for whatever reason, they did a non-contrast abdomen pelvis.
Hmm.
And the radiologist who read it very astutely picked up on the fact that this 18-year-old male had a little bit of free fluid in his pelvis, which is not normal. And so they transferred him to us. And, the kid was kind of a punk and we were sort of blowing him off a little bit, in all honesty. And we repeated his abdomen pelvis CT with contrast. And next thing I know, I see that he's admitted to our trauma intensive care unit. And I grabbed the trauma resident. I'm like, why is this guy going to the TICU? And they looked at me like I had three heads. And they're like, well, all grade 5 splenic go to the TICU. And I was like, are you kidding me? And went back and looked at his non-con images, and you could not tell.
Wow.
When you looked at his contrast images, his spleen was shattered. And so it was a great, sort of learning case, but you absolutely need contrast on board to look for solid organ injury. Those are
I'm
sort of
gonna I'm gonna interrupt for just one second, not to make this conversation about me, but these real life examples. Same thing. I had a very traumatic fall, and I fell straight back onto a cabinet. I was long story, but I hit my back really hard, and I hit the right side of my flank, and it was a terrible fall. I went to the ER. And he said, we're going to order a non-con. And I was like, that just doesn't seem right. Like, I'm in so much pain. There's something really wrong. But they did the non-con. He comes back. He says, looks good. You can go home. Gave me some Vicodin. I got worse. And let me just tell you, it wasn't just the back pain. It was belly pain. There were all these things. So I went back and I had to get another CT within 24
Hmm.
hours, which I hated. And they used contrast. I had a liver lac, a splenic lac, and I had ischemic bowel. And I was admitted for almost a week.
wow,
Yeah.
quite the fall, my dear.
Yeah.
Yeah.
So, some of those things probably evolved a little bit over time. I did go to the ER pretty quickly after my fall, but it's shocking. And I later looked at the images, like you said, and you could not see them. So,
It's terrifying. So for trauma, you really do need contrast on board. Really, in this day and age, the only reason for not using IV contrast, particularly in the abdomen, would be if you're really convinced that it's renal colic. And I know we're going to touch on that a little bit more in a few
yeah.
minutes. But for the vast majority of things, contrast is really going to help. If you're worried about infectious etiologies, contrast is really going to be able to help you with that, particularly if you're worried about something like a drainable fluid collection. If you have had recent surgery and you're worried about distinguishing between normal post-op changes and infection, contrast can sometimes help with that. So in general, for most things, we're going to want contrast on board.
What do you like without getting too deep into this? Like, what do you think compelled people to say, like, we're worried enough that something's bleeding into their belly, so we're gonna get a CT scan, but we're not doing contrast. That's where I draw the line. Like, what would possess them, do you think?
Well, I think a lot of that stemmed, and I think again, we're going to touch on this in a few minutes, but a lot of that stemmed from this complete phobia that developed in the medical community around IV contrast and renal
Hmm.
insufficiency.
Okay. Hey, we're reading ahead a little bit. We're kind of like planting the seed here. This is good.
I, I,
Okay.
I think, that's a whole discussion, but I think that's where a lot of this reluctance to giving IV contrast came.
Hmm.
You have an older patient, maybe the creatinine was a little tenuous, and you'd be like, they fell, they have a little bit of belly pain. Let's just get the non-con. Reality, you're not answering any questions there, and you're really potentially worsening their care. So, but I feel like that right there was the big push for not giving IV contrast more liberally.
I'll pull the trigger on non-con CTs with sometimes bony trauma. Like if Like, maybe tibial plateau fracture, like X-ray looks good, can't walk, let's get a CT scan.
Absolutely. For most orthopedic stuff, unless you're worried about concurrent vascular injury, which,
Hmm.
generally there's going to be some good evidence for that. If you're worried about a knee dislocation with popliteal artery injury, then yes, obviously you're going to want contrast. But if you're worried about like an occult tibial plateau fracture or something like that, non-con is going to be fine. For most routine orthopedic stuff, non-con is fine. Spinal CTs, non-con is fine. Um, but that's sort of about it,
Yeah.
honestly.
Cool. Fractures and renal colic is kind of where I go. Yeah. Okay. Okay. Switching gears to MRI. When do we know to order MRI with or without contrast, or the dreaded with and without contrast? Like, are there particular times where themes again with this, and what are we really doing with the contrast? Like, probably we're trying to identify some vascular issues with contrast, but can you explain kind of any broad themes here with MRI?
MRI is tricky. I always tell my trainees at the end of the day, it doesn't really matter what we order because a radiologist is always going to protocol an MRI.
Hmm.
So there's always going to be sort of a higher set of eyes looking at that, as long as you put in your indications what you're exactly looking for.
That's so
Uh,
key, right? Yeah, like tell the radiologist what you're
you
looking
have to
for.
be specific what you're worried about and what you're looking for on the MRIs because every MRI gets protocoled by a radiologist.
Huh.
Uh, because there's so much nuance to the MRIs and the different sequences that are involved and everything. So a radiologist is always going to protocol it. So you always have that a bit as a backdrop. However, in terms of general concepts, contrast helps a lot to help further delineate soft tissue structures. And so on the MRI, and again, I'm going to sort of concentrate on emergent MRIs.
Hmm.
We're not going to be
Of
talking
course.
about shoulder MRIs, as an outpatient and stuff. That's a whole nother beast. But for the stuff that we worry about, a lot of that is going to be CNS processes, right? And
Right.
so when someone comes in, you get an abnormal head CT and you're worried about a mass lesion, or is it a mass versus, say, an abscess? Contrast is going to be really critical to help you differentiate that. So if you're worried about infectious etiologies, if you're worried about distinguishing and further characterizing mass lesions in the CNS, contrast is going to be really helpful. And that's a case where you're going to be getting with and without. Things like MS, there's a bit
Hmm.
of a debate about whether we should be MRIing people from the ED for, question of MS or not. I do feel like in some cases it actually does impact their immediate care, in terms of like, do we admit them for high dose steroids or whatever?
Hmm. Optic neuritis, right? If that's a concern.
Exactly. Contrast can help with that because with MS, you see all these lesions, and the question is, are they active or are they not? Post-contrast imaging can help differentiate for the radiologist, are these active MS lesions or not? So in that case, with and without is very helpful. Um, in terms of spinal imaging, if you're worried about infection, like an epidural abscess, you want contrast on board. That's going to be really critical for that. If they've had any history of prior spinal surgery, you're going to want contrast on board because a lot of times
Hmm.
post-surgical changes on a non-contrast MRI can be a little bit difficult to distinguish between just normal post-surgical changes and infectious changes. And so the contrast can help with that as well. So if they've had any history of spinal surgery, in general, you're going to want to with them without. If all you're worried about is, you get a great story for like an acute lumbar radiculopathy, like somebody, bent over, felt a huge pop, and now like can't move the right leg, and you're worried about an acute lumbar disc, you don't necessarily need contrast for that.
Hmm.
If it's a virgin spine and they haven't had surgery and you're not at all worried about infection. Most our ED, and we do a lot of MRIs. We have an MRI right in the middle of our ED, so we do a lot of them. We've developed an acute core compression protocol,
Hmm.
which is sort of a spinal screen protocol. And that, by definition, is a with and without, because on that differential are things like spinal epidural abscess. And so we end up doing in practice a lot of with and without spines. But if all you're worried about is like an acute disc or something like that, then you can generally get away without contrast.
Hmm.
But for a lot of these, they're going to want contrast on board. But like I said, at the end of the day, it's not always up to us to order that. A radiologist is always going to be protocoling these and sort of making that final determination. One point I wanted to bring up, though, you mentioned vascular phenomenon. What a lot of people don't realize is a lot of MRAs, so MR angiographies, particularly in the head and neck, are done without contrast,
Huh.
which
Hmm.
sounds very sort of counterintuitive, but they call them time of flight sequences. And basically, what the MR is measuring is the flow of the protons in the vessel. And so many of them are actually not with contrast. There are contrast enhanced protocols. You can sometimes specifically ask for contrast, but your routine MRA, brain and neck are typically non-con.
What about this term post-processing that they do for CT angios in regards to this type of workup?
So post-processing refers to is you scan and you obtain a set of what they call source images, which are axially acquired slices this way. And from that database, from that set of images, they can then take it and do all sorts of computerized manipulations. And so they can change the plane of the image, they can alter the contrast levels, et cetera,
Hmm.
and highlight different things. There's a whole technology out there called dual energy CT, which is a talk way in and of itself that allows them to do some very sophisticated post-processing where essentially you scan at two different frequencies. And for instance, you can scan an abdomen with contrast, and with the dual energy, they can then go back in and post-process out the contrast. So you can essentially get a non-con image with a contrast scan. And so if you're really worried about like renal colic, you can just give them the contrast and get
Yeah.
all information, and then you can post-process it. But in general, when they're talking about post-processing, what they're talking about is manipulating that axial source data into different planes and highlighting different sort of things. There's a
Hmm.
limit to what they can do, but the slices they obtain, particularly in the CNS, are so thin and such high detail that they can really do some very sort of sophisticated reconstructions with those images.
Wow. All of this is so incredible. I wish that we had 20 hours, but if you want the 20 hours, you can go to the course, right? So let's move on a little bit because I do want to talk about some of these other topics, but I still have this burning question about contrast allergies. And what do we do when someone says they have a contrast allergy to either CT or MRI contrast? And is this a real thing?
The first thing you do is curse loudly, because it never ends up being easy. Um, so this is a huge topic. Starting with some definitions. Most contrast reactions are not true allergies. About 90% of them are not IgE mediated. They're not antibody mediated. They're what they call idiosyncratic or pseudo-allergic reactions,
Mm.
meaning you can have a severe reaction without any prior exposure to contrast. So unlike true allergies, typically you need, some sort of inciting exposure, you build up an antibody response, et cetera. With contrast, the vast majority, like I said, 90+% are idiosyncratic. What that also means, though, is that you can get contrast again and not have a reaction. And so it's not an absolute. So if you've had a reaction to contrast in the past, there's no guarantee that you would have it again, even with a severe reaction. So they're not true allergies in that sense. And so for that reason, I like to call them contrast reactions and not necessarily contrast allergies.
Mm.
The other important thing to keep in mind is that they're incredibly rare. So the CT contrast or the IV contrast that we use nowadays is not the IVP dye from like our parents and grandparents' generation. That was a totally different beast. The rate of reactions was much, much higher in those cases. The newer dyes are incredibly safe. And they estimate the rate of reactions is like something like 0.004 to 0.00004. Like
Wow.
incredibly rare in terms of serious reactions. People have a lot of side effects from the injections. And so the first thing when someone says, "Oh, I've had a contrast reaction," is dive into that. The devil's in the details. And so you really want to probe the patient a little bit and see what exactly was your reaction. Did you get a warm flush feeling and maybe feel a little bit itchy without anything else? If that's the case, move on. You're good. If it's my throat closed and I couldn't breathe and I had true anaphylactic type reaction, that's a different story. Um, the other thing is, when did you have that reaction? Again, was it 30 plus years ago when you had an
Mm-hmm.
IVP? Or was it 3 days ago when you came in for your chronic abdominal pain and you got your CT of the year, right? And so, again, the devil's a little bit in the
Uh,
details. Also, questions I like to ask are, particularly in older patients, have you ever had a cardiac catheterization? Or I will sometimes look in their chart and see, had they had a cath in recent years? Because it's the same dye. And if they didn't have a reaction then they tolerate it. So sometimes the history can sort of tease it out. If they say, I have a contrast allergy because I'm allergic to shellfish, this is one of my favorites. That's not a reaction at all. There's no cross-reactivity. There's people are allergic to the protein in the shellfish, not to the contrast. But this myth is perpetuated even within medicine. And I still have, CT techs that will call me and they'd be like, hey, they're allergic to shrimp. Should they get the contrast? And the answer is yes, absolutely.
I
There is
think so, yeah, I think people are listening to this podcast simply for this answer, honestly. So
so
can you just repeat it again? If I say I have a shellfish allergy, can I have contrast?
absolutely welcome. You're welcome for the contrast. Sorry about the shellfish, but yes, you can 100% have contrast. Um, Similarly, if they say I have an iodine allergy, we see this one a lot. Well, what's your allergy? Well, they put betadine on and my skin got itchy. There's no cross-reactivity there. And that has been thoroughly debunked. You can give them the contrast. Iodine is an element. It's a necessary element in our bodies. It's in everything that we eat. It's in our salt. We need it for our bodies. You cannot be allergic to it. You can have a contact reaction to topical preparations
Mm.
like betadine, but that does not mean that you're going to be allergic to IV contrast. And that's been shown. So if they say I'm allergic to betadine, give them the contrast. The caveat to all of this and the conversation that I have with patients is if you're an atopic person, like you're prone to allergic reactions, in general, you're going to be more likely to have a reaction to contrast. Not because you're allergic to shellfish, but because of your atopic
Just
makeup.
generally, you are. Yeah.
Generally, you're more likely to have a reaction.
Well, that
And
kind of brings
so,
us to question 4.
Yeah. Oh, I think I was told one time, I think Kevin Clower mentioned this in one of his lectures. There's more iodine in chicken than there is in shellfish. So it's like no one has a chicken allergy, right?
yeah,
That we put on our records,
right.
right? Um, I, you mentioned also like iodine, like a naturally occurring element required for our thyroid gland to do thyroid things. I had a patient the other day who said she was allergic to water, which raised so many
Nuh-uh.
questions.
Yeah,
They also said they were a nuclear war veteran, so I of course thanked them for their service, but then I disposed of them appropriately after that.
yeah,
Um, so getting to that reaction question, of course, the next thing is, well, I guess it's a two-part question then. Like, so I suppose when someone says like, "Yeah, my throat's straight closed," they had to hit me with the epi. That's probably where it's like at least there's some wiggle room there, at the very least wiggle room, and maybe that's a true allergy. But is it those patients where we should be pre-medicating? Are there other patients where pre-medication is beneficial? And are there any particular, I mean, not to get way into the weeds here, but any particular pre-medication protocols beyond like antihistamines and steroids we should consider?
sure. Um, my take-home advice is if it is truly an emergent study, and I just had this the other night, I was working in our critical care, had a 70-year-old patient come in with an acute stroke.
Hmm.
And it was clearly, they had a clinically a very, dense MC right or left MCA syndrome. They were aphasic, they're hemiparetic. They had a anaphylactic contrast reaction. We discussed it with the family. We went ahead and we did the scan. And we're like, there's no telling that they will have another reaction like that. If we don't get this information, it's really going to limit our therapeutic options in terms of thrombectomy. And the other thing is they're in the emergency department. If they're going to have a reaction, this is the place to have it. And we were ready. We had epi ready. We were on, we gave them steroids and Benadryl just to sort of ward off the bad juju, knowing that
Right.
that's not the way that you do a pre-medication. But in this case, it becomes a risk benefit. If you have time and it's urgent, not emergent, the recommendation from the American College of Radiology is that you pre-medicate them. Anything like a moderate to severe reaction. So anything beyond just a few simple hives, like if they get some trouble breathing, a little bit of, severe urticaria, they classify that as like a moderate reaction. Anything with, anaphylaxis or airway involvement would be severe. They recommend that if you need the study to pre-medicate them. Their pre-medication regimens are a little ridiculous. Their preferred is a 12-hour
Oh my.
oral steroid pre-medication. You give steroids at 12 hours, you give steroids at 2 hours, and then an hour before you give Benadryl, and then you do the scan. Obviously, that's not practical for us. What they have compromised on is a 4-hour IV steroid regimen where you give steroids 4 hours before the scan and then a dose of an IV antihistamine an hour before the scan, which is what they recommend. And again, it's going to be a little bit institution dependent on how much your radiologists are going to hold you to that. Our radiologists are fairly reasonable, but if they do have a documented moderate to severe reaction, they ask us to hold to that protocol. And so you're buying 4 hours of pre-medication time.
Hmm.
The ACR fully acknowledges in their guidelines that it's a little schizophrenic, that they may never not have a reaction anyway. Pre-treating has not been shown to totally prevent what they call breakthrough severe contrast reactions.
Hmm.
And they said, so the data is very limited, but we still recommend it. So you have the professional society, that's their official recommendation. So my feeling is if it's truly emergent, like if I'm worried they're having, like really worried they're having an aortic dissection, I'm going to scan them. If I'm worried they're having a large vessel
Yeah.
occlusion, I need a thrombectomy, I'm going to scan them. If I have some time to wait, I will pre-medicate them with the 4-hour protocol. And that's sort of my practice, and that's what our radiologists have sort of approved in our institution. So
I like the nuance. I mean, I
Yeah.
think it's good to have some degree of
there
nuance.
is a
And
lot of nuance, and honestly, some of it comes down to a risk benefit. And like
yep.
when you ask the patient what they want, and be like, "Look, there's a chance you could have a reaction, but you're in the emergency department. We're experts in this. We're going to watch you very closely." My experience, a lot of the patients are like, "Yeah, let's just do the study." I'm like, "I don't want to wait for 4 hours."
Yeah. Yeah.
Oh, I didn't even consider that. So yeah, you could have like the
Have a shared
discussion, and you could
decision.
document thoroughly, like we'd had the discussion, and
Yeah.
hmm.
And in my experience, the vast majority do fine because again, true contrast reactions are very rare, thankfully. So
Well, all right. Let's move on to this question we sort of alluded to earlier. How high, and this is just one of the burning questions. How high is too high for creatinine if we want contrast? If it's a little high, like 2, can we hydrate patients and use contrast? How do we go about making these decisions?
love this question. Nice, easy softball here. There have been over 1,000 articles published on this.
Hmm.
I'll summarize all of them. Get ready. Um, my honest opinion, and in reading literature, I think contrast-induced nephropathy is not a thing. Nephrologists will disagree with me, and they do. Um, this idea of contrast-induced nephropathy started in the 50s when case reports were coming out from IVP dye that was a totally different beast, and it grew into this complete phobia in the medical community. And like I said, this has been studied ad nauseum, like literally over 1,000 papers are out there on this. They define it as a rise in creatinine, variably like 0.25 to 0.5 over baseline, um, over a period of time after receiving IV contrast. When they have looked at actual patient outcomes, like the need for renal replacement therapy, like dialysis, um, in large population-based studies, and there was one that was over 6 million inpatients, those who got contrast, those who didn't. There was no statistical change in the rise in creatinine or the need for renal replacement therapy. So no difference really in either a lab value or in a patient-oriented outcome like the need for dialysis. And so our radiologists have taken the tack that if we need the study, we do the study. And we don't even bother with the creatinine. We don't bother, aggressively hydrating. And there's actually some data out there that aggressively overhydrating to try and correct for this may actually cause more kidney injury
Hmm.
than the contrast itself. And so, again, this is still unfortunately very hotly debated amongst nephrologists. They sort of refuse to give up on this.
Hmm.
I've brought them to our conferences to debate this, and they bring out rat data from like the 70s and
Yeah,
80s.
great.
When you really look at true patient-oriented outcomes, there's been no difference. And so, again, my feeling is, and this is my opinion, but it's based on a lot of literature out there and a lot of consensus, if you need the study, do the study. You do more harm by withholding contrast studies in patients who would benefit from the diagnosis and interventions than you do by giving the contrast. And again, I fight this fight with the nephrologist all the time. Our radiologists fight the fight with the nephrologists. The one, I'll be completely honest, the one caveat I have is in renal transplant patients.
Mm.
I get nervous with them if they have any degree of like, renal insufficiency. Not that I think that the contrast is going to kill their kidney, but whatever process is bringing these people into the hospital, that's in all likelihood what's causing the renal injury.
Yep.
It's their sepsis, it's their MI, it's their shock, it's it's whatever's bringing them into the hospital that's leading to the CT that probably causes the renal injury. But if you kill someone's transplanted kidney goes, 100% they're going to throw you under the bus.
Yeah.
You're getting an email about that one. Yeah.
You're getting an email about that. It's going to go in the chart that, reckless ER doctor gave this, willy-nilly gave this transplantation contrast and killed their kidney, So those are the only ones that give me a little bit pause. But again, if they really need it, I do the study. And we just have that conversation. So, but again, a lot of it comes down to the institution. There are many institutions out there still where even the radiologists, if their creatinine's 2, they'll balk at giving the contrast. And I really feel like we're doing our patients a disservice by doing that.
Hmm.
The rat literature is really interesting. The hard part is having the shared decision-making discussion though with the rat, right? It's like, okay, you gotta like get really low on their level,
Yeah.
waiting for an interpreter forever, like it's so
Rat
long.
interpreter.
Yeah, exactly. What press
Because
79 for a rat interpreter. Yeah.
and the patients come in and they're like, my nephrologist said never give contrast. They're going to kill my kidney. I'm like, well, I'm worried you have a dissection. We should probably
Yeah.
contrast. And they
Yeah.
adamantly refuse, and it becomes very frustrating for everyone.
Hmm.
I'm hoping that as more and more of these big population-based studies come out, that we can hopefully sort of lay this to rest. The other confounder I will say though is intra-arterial contrast. So with cardiac catheterization and stuff, that is much less well studied, and I do feel like that is a bit of a different beast because you're giving it intra-arterial, so it's hitting the kidneys first pass, and they tend to use much higher doses than we use with a typical CT. So I don't think we can totally extrapolate that to procedural cases. So that's my only caveat. But I think in terms of routine CT contrast, I feel like if you need the study, do the study.
That's an interesting wrinkle. I never thought about that. Okay. Very cool. My white whale neurologically is the cerebral venous sinus thrombosis. Like I really get excited about like thinking about that. I've even made a little mnemonic, tipsy as far as like risk factors for like acute and chronic risks for CVST. And so like I think about, and if you don't think about it, you're never going to find it, right? So I think about it with funny headaches, with the young person that shouldn't be having a stroke, but it sure looks like they're having a stroke. And so that's kind of a less often ordered study. You might not even be able to find it in your EMR sometimes. You can't just dial up CT venogram. So can you kind of discuss that, how that study differs from the usual CT vascular studies we're doing? And what do we do if we want to order it, but it's not quite pulling up in our directory?
So you have two sort of options if you're worried about venous sinus thrombosis. So you can very often see some findings on a non-con CT, but they're not necessarily specific. Every once in a while, you'll see a big, dense, clotted sinus on a non-con CT, and that's great because that sort of makes the decision tree very. But if you're worried about venous sinus thrombosis, which again, it's a tricky diagnosis. The median time from symptom onset to diagnosis is about a week. There's often a few ER visits in between there, and so it's a tricky diagnosis to make. But if you're worried about it, you need a venogram. And so your options are CTV and MRV. They're both excellent tests. CTV sensitivity approaching 99%. So in terms of like diagnostic studies, it's phenomenal. It used to be much harder to get. I feel like now that we're getting vessel imaging with all of our stroke patients, I feel the general ER radiologists are much more comfortable reading cerebral vessel imaging. And so it's become a lot more accepted to get a CTV. General EM radiologists are more comfortable reading them. And in terms of just ease of getting the study, in the vast majority of institutions, it's going to be much easier and faster to get a CTV than it is an MRV. with pretty equal, it's almost equal diagnostic capabilities. So the difference is all in timing. And so when you do a CT angiogram, like a CTA of the head and neck, you're obtaining those images earlier in the contrast administration, whereas a CTV, they obtain the images later. And there's also early and late venous phases
Hmm.
to think about. But if you're ordering a CTV in general, it's a CT brain with contrast that they just do delayed image acquisition on. And that
Hmm.
gives, hopefully will opacify the venous sinuses and let you look at that. So important to know that if you're ordering a CTA for like a suspected stroke, most of the time you're not going to be able to rule out a venous sinus thrombosis on that CTA. You really need the delayed CTV images.
Hmm.
An MRV, again, is interesting, and it comes down to your institution. Like I said with MRAs, a lot of MRVs don't actually use contrast. Again, they're sort of measuring the flow of the protons.
Hmm.
And if that's the case, it's actually not as good a test as a CTV.
Okay.
If they do contrast enhanced MRVs, then it's a great test. But again, time comes in. It's a much harder test to get, and it takes longer to get the images. The benefit of doing an MRV is that it shows you an MRV in combination with an MRI, is that it allows you to assess for some of the complications of a venous sinus thrombosis,
Right.
of which one of the biggest is a venous infarct. So like
Hmm.
you said, when young people come in with stroke symptoms, you're like, something's not right here. Great to think about venous sinus thrombosis because you can get venous infarcts, and they tend to present less abruptly and less well sort of localized to a specific vascular territory. Because they're venous, they tend to be a little more widespread,
Oh.
more time to develop. The MRI in conjunction with an MRV can help you assess for that. Whereas a CTV is pretty much only going to give you the diagnosis of a venous sinus thrombosis.
Hmm.
But if as a screening test, CTV all the way. I think that's where your money is going to be at. And if you're having a hard time finding it in your EMR, call your radiologist or call you in our place. If I'm having trouble ordering something, I'll call our CT techs and be like, this is what I want. How do I need to order it in Epic? How do I need to order it in our EMR? And they'll tell me the order and I'll put it in. We're a big stroke center. And when someone comes in and activated as a code stroke with concern for an ELVO, an emergent large vessel occlusion, and they're a thrombectomy candidate, our protocol is they actually get 4 scans. They do a
Wow.
non-com, a CTA, an early and a delayed venous phase because our neurointerventionalists look at all of that.
Hmm.
If that's the case, you got your CTV and you don't need to send them for a separate one. But that's sort of a nuanced question that, if you really want to know, go talk to your radiologist and see what your institutional protocols are.
So, do you talk about these in more detail in your course? Because even I need a little more education on these. I mean, that helps a lot, but do you
Yeah, for the
image
C
it, like see pictures and things like that?
for the head CT stuff, we do talk about some of that, and we talk about venous sinus thrombosis exactly, and sort of the diagnosis of it.
Well, I'm
Sweet.
in then. Okay, if you talk about CVST, I'm going to your course. That's for
Yeah.
sure.
Well, that kind of leads me to question number 8 because we don't have a ton of time, but I did want to just end with 2 particular diagnoses we're looking for and how we go about working them up. And we get this one a lot at boot camp, and I saved it for the end. And we do have one question about plain films before the end of the show as well. But, you know, I just want you to review the imaging guidelines for subarachnoid hemorrhage and if we should go ahead and get an LP, if and when the CT is negative, and if we should still be concerned about subarachnoid hemorrhage.
So great question. A lot of depth to this. The Canadians came out with a study saying that if you get a non-contrast head CT on a modern CT scanner within 6 hours of symptom onset, if it's negative, you've effectively ruled out subarachnoid hemorrhage. I disagree with that. I've
Hmm.
seen at least a half a dozen cases in my own practice that were CT negative, LP positive within that 6-hour window. And when you're dealing with a potentially life-threatening or life-altering diagnosis, I want to be certain. That's my own feeling. If you are going to abide by that 6-hour head CT rule, and you're in good company. I mean, that's what, at the ASAP clinical policy on, workup of acute headache, they talk about this, and they do say that, That's an acceptable, literature-based approach that if you get the head CT within 6 hours and it's negative, you can, with great confidence, rule out a subarachnoid hemorrhage. But they then go on to caveat it and say that if you're still worried, based on clinical concern, continue the workup. So even then they hedge. And the next recommendation, the next question then comes, should we CTA these people? And if that's negative, can I forego the LP? And again, based on the limited literature that's out there, CTA is an excellent test to look for aneurysms. It's roughly, 97 to 99% sensitive. And the vast majority of spontaneous subarachnoid hemorrhages are going to be aneurysmal, at least the dangerous ones. And so if you rule that out, do you need to move on to an LP? Again, I think you're supported if you don't, but my clinical practice is if I am worried about it and the imaging is negative, I'm still going to LP that person because this is a devastating disease if we miss it, and I want to be sure. If it's like, yeah, my head hurts and they're texting on their phone and eating Wendy's takeout in the ED, like, yeah, worst headache of my life. Ha 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 ha. Am I going to LP that person if all their imaging's negative? No. But if they're clutching their head, can't move their neck, they're vomiting, mom died of an aneurysm, and their imaging's negative, I'm still going to LP that person. And I had that case about 6 months ago. Their CT was stone cold normal within 2 hours of symptom onset. They're non-con. We CTA'd them at the same time. It got read as negative. When I went back and looked at it, there were bilateral ICA aneurysms. Radiology missed. And we tapped her, and it was like cherry Kool-Aid coming out.
Oh my God.
Her non-con was negative, even in retrospect. So my feeling is if you're going to use that 6-hour head CT rule, you got to look at your own images. You got to satisfy yourself that they're negative. I've seen cases where the CT got called as negative. You go back and look at it, and there's clear subarachnoid blood there, and it just got missed. So if you're going to use that 6-hour rule, make sure you look at your images and make sure that it's really negative.
Yeah.
If you're still worried about it, if their clinical story, if your spidey sense is going off, I still tap those people.
Yeah, I think I did an LP about a week and a half ago. I hadn't done one in a little while. And I thought to myself, oh my God, now I'm not going to be able to leave on time. It's going to take me hours. I got to do all this stuff. Honestly, the entire procedure took me 7 minutes.
Yeah, it's really,
It's not that long.
they talk about the risks, epidural hematomas and infections and this, that, and the other thing. I've seen one epidural hematoma from a spinal tap in 20 plus years of doing this. And that was one done by radiology. It wasn't even done by us.
Yeah.
Yeah.
There you
Post-LP
go.
headaches. It's a thing. But post-LP headache versus missing a subarachnoid hemorrhage, I'll
Yeah.
take the headache any day. So that's my practice. Again, the literature would support it. Another caveat to keep in mind, though, is that if you really delve into the details of the Canadian study, they were read by neuroradiologists, which is not going to be the case in most places. And also, patients' hemoglobin levels actually matters. So if they're anemic, if their hemoglobin is less than 10, the sensitivity for head CT way down. Because you're looking for the density of the subarachnoid blood. And so if they're baseline anemic, their blood is going to be less dense and it's less likely to show up on a non-con.
Wow.
And that's a nuance that a lot of people don't appreciate, and they just broadly apply the 6-hour rule. So again, devil's in the details, and you got to be a little careful with this.
Okay.
I've heard that if you don't LP and there is actually bleeding, you miss it. I've heard a Canadian is required to call you and say sorry, like we sorry.
Exactly.
Well, we're gonna go all the way back now to the Röntgen Society and plain films. Okay, so often people will come in because they took a shot to their rib cage and were worried about a rib fracture. And like my personal practices, like I frankly don't care if you have a subtle rib fracture. Like what I care about is the rib going straight through your lung, and now you've got a pneumothorax. So that's what I really care about, honestly. So in terms of rib fracture imaging, plain radiographs, with a rib series, as they say, kind of shooting the ribs from different angles with planes versus ordering a CT. What is maybe your practice personally versus are there any sort of general recommendations here? Do you have any broad thoughts about that?
So I'd never get rib films.
Oh,
sensitivity is 30 to 60%. And again, it's a terrible test. I will get chest x-rays to start because again, I'm worried more about the complications in young people. So I'm worried about pneumothoraces, I'm worried about a hemothorax, etc. Older people are a different beast, and there's some older data, but there's some older data that would suggest that in patients who are 65 or older with 2 or more rib fractures, their mortality is twice that of younger patients with the same injuries, just given the rib fractures. And that for every rib fracture over those two, their mortality goes up by almost 20%, just due to the comorbidities from the rib fractures. So our trauma colleagues at our institution are very aggressive in finding and treating rib fractures in older patients. And in fact, our protocol is if you're 65 or older with 2 or more rib fractures, that's a guaranteed TICU admission for aggressive pain control and PT, et cetera. Age 45 and older with 4 or more rib fractures, it's been shown to increase their hospital length of stay, their ICU length of stay, et cetera. So if it's a young, healthy kid who took a hard shot to the rib cage and they're focally tender over 1 or 2 ribs, I'll get a chest x-ray. If they don't have a pneumothorax, I'll say, yeah, you probably have a rib fracture. I'll give them an incentive spirometer and teach them how to use it. I'll give them some good pain control and send them on their way. If they're 65 or older and I'm worried about rib fractures, I'll do the chest x-ray because it's quick and easy, but I will typically follow that with a CT of the chest because at least in our institution, that will dramatically alter their disposition and their prognosis. So they're not as benign as people think in older people. And so I'm a little bit more aggressive, and we're all a little bit more aggressive here in diagnosing them in older patients. The other caveat I will say is that the radiologists miss them all the time, even on CAT scan. And I actually went to give grand rounds to our radiology department, sort of, I called it bridging the gap, like talking about the things that like they do that drive us nuts and stuff that we do that drives them nuts. And I talked about the rib fractures, and I threw up some of the morbidity and mortality data, and they were like mind blown. Because like, why do you guys care so much about the rib fractures? You don't do anything with them anyway. And I was like, well, actually, we do. And older people and older patients, that actually makes a big difference. And so they were they were terrified. They're like, oh my God, we barely look at these. And so
Oh, thanks.
Thanks a lot.
that's reassuring, right? And so I really look carefully for the rib fractures in older patients. But again, young and healthy, their vitals are fine, their incentive spirometry is fine, their chest x-ray looks clear. I'd be like, clinically, you probably have a rib fracture. Here's some pain control. Here's an incentive spirometer. Good luck. If they're older, a lot of comorbidities, I will often move to CAT scan.
You dropped that like 45-year-old number there, and so that's kind of like in between, right? So in that patient, like, would it be one of those things where like, hey, we might be admitting you anyways because everything else is so rough with you? Would that be kind of your trigger of like, let's get a CT? Like in that in-between time, when are you considering CT for rib fractures?
It's gonna sort of come down to the patient and like what their trauma was. You know what I mean? If clinically, I think they have more than just like an isolated rib fracture. Like if they're tender, like their entire chest, or if I'm feeling crepitus, or I'm feeling, you know what I mean? Certainly, if they have any sort of other comorbidities, I have a lower threshold for scanning them. If they're a young, healthy 45-year-old and be like, yeah, it hurts just right here in one spot, and I felt, up against a door jamb and it hurts like right in this one area and they look great, I probably wouldn't scan them.
Because it's so focal, right? Like one rib fracture, young person, no big deal. Multiple
I love that 45,
comorbidities.
45 is young, right? And so,
Oh, totally. It's very young. Yes.
so yeah, if they're at all sick, if they have other comorbidities, if they're severe COPD, or if they're, other comorbidities where I'm worried that they're going to get into trouble if I miss their multiple rib fractures, then I have a lower threshold for scanning them. But it does come down to a bit of a judgment call. If they're inordinately hypoxic and I don't have a great explanation based on their chest x-ray, I might consider scanning them. The other thing to keep in mind is that chest x-ray for pneumothorax is also not a great test. A good upright chest x-ray, 50 to 60% sensitive. And so it's not the best test to look for pneumothorax. But again, if they're stable, they're ISing fine, they're probably going to do just fine, even if they do have a small sliver of a pneumo. So
all goes back to the history and physical exam. That's very troubling, honestly.
yeah.
I wanted to just CT people and get over with.
Well, we are so lucky to have had you today on the show. I wish that we had more time, but honestly, if you guys want more, we've already told you how to get it. So some Final thoughts here. Our audience really loves when we recommend some online sources or pocket guides. Is there one particularly special or useful to you for imaging in order to, either look at imaging or decide how to order imaging or interpretation, et cetera? What do you like?
Um, there's a great textbook that I love. I use it in my core in the elective that I teach the residents by David Schwartz. It's called Emergency Radiology Case Studies.
Hmm.
Older, it's from like 2008. You can get it on Amazon used. It's an amazing textbook. Dr. Schwartz did an incredible job. He's a emergency physician at Bellevue. I've never met him personally. I have no royalties associated with his book, but I probably bought 30 copies of it over the years because my residents keep stealing it on me.
Yeah.
That good. It's case-based. It's very readable. It's a great emergency radiology baseline text. In terms of questions about imaging modalities, there's not a lot out there in terms of like pocket guides, but what I would refer people to is the American College of Radiology appropriateness criteria. And so for every disease process that has imaging as part of the diagnosis, the ACR has put together panels, multidisciplinary panels that go through and they look at the literature for every imaging modality associated with that disease. And they offer recommendations on like what is the most appropriate, what is second line imaging, and what to avoid. So for suspected head trauma in kids, they will say, follow the PCARN guidelines. If they're higher risk and you need to get imaging, start with a non-con head CT as their, top tier recommendation. They say do not get skull films at all. They're not warranted. But for every disease process, they will go through and they will tell you what the appropriate first and second line imaging to get is. And then if you look in the notes after the tables, it will go through the literature behind that. And so it's for things like occult hip fractures, MRI is the gold standard test. And so when I'm trying to admit a patient from the ED with a suspected occult hip fracture, they can't walk on it, their plain films are negative, and the hospitalist is like, well, just get a CT, and if that's negative, send them home. I send them a link to the ACR appropriateness criteria. And so I find that to be very helpful.
All right, we will link all that in our show notes. All right, Mike, you want to take us home here?
Well, I had one quick question. But it's probably right behind me on my shelf. There's this book out of I think the Great British Isles. Great, I guess it's debatable, but the British Isles. And it's called Accident and Emergency Radiology: A Survival Guide. I think it's in the third edition. It's kind of portable. Do you have any thoughts, pro or con, on that one?
I haven't actually seen that one. It's probably pretty good. Is it mostly plain film?
I think there is some advanced imaging in there as well. I think it's mostly plain, but I think that with the third edition, I think they've incorporated some advanced imaging as well.
I will check that one out. I'll get back to you.
Yeah, Accident and Emergency Radiology: A Survival Guide, now in its third edition. That's been one I've been using. It's relatively portable, but not as portable as an online ACR appropriateness. That sounds very point of care accessible. So I like that resource.
And actually, a lot of EMRs have built the ACR appropriateness criteria into their ordering, so you may actually see that in your own EMR. And so again, it sort of like brings you up to guidelines in terms of what you're ordering. So
nice.
Great.
Well, this was great, Bob. We have a two-view trivia question we usually wrap up the podcast with, and I'm curious to see if you know this one. We'll kind of put you on the spot here. So our trivia question for last month had to do with what's called the Oropouche virus. I'm just so excited I get to say that word again, Oropouche. But what is the Oropouche virus named after, and in what year was it first discovered? Any thoughts on that one?
absolutely not.
Oh, okay. Well, as Martha and I are aware, the Oropouche virus was named after the village Vega de Oropouche in Trinidad and Tobago, and that was first
right on the
discovered.
tip of my tongue.
You were right there. I know you were probably like it sounds Trinidadian or Tobagan, either one. And it was first discovered in 1955. We actually had somebody who did the due diligence here and looked this one up. They have requested to remain anonymous. However, perhaps they're from Trinidad and or Tobago. But we have a new question for us, Martha.
Okay. Well, this month we ask, in what year was the CAT scan invented and by whom?
Rob, don't
So
say it. I know Rob knows that one, but don't. Yeah.
don't tell us. We'll tell
Okay.
you
Well,
next month.
email us your answer or any feedback or comments from this or any episode to 2viewcast@gmail.com. That's the number 2viewcast@gmail.com. Rob, this was great. Like I really I had high hopes with this episode, and you really blew me away on this one. I'm just so excited to learn more during the course with you and your co-presenter, and it's been great having you.
Thank you guys so much. It's been truly been an honor. I love geeking out about this stuff. It's awesome. So thank you for giving me that opportunity, and good luck, everyone.
You
Thank
are
you
in
so
good
much.
geeky company, that's for sure. Yeah. Well, more information on this radiology course, on the original and advanced emergency medicine boot camps, the emergency medicine and acute care course, or any of our courses are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
All right. Well, new and upcoming courses to be announced soon, but keep checking back for more on the advanced boot camp, the original boot camps, and all the courses we have to offer at CCME.
Thank you for listening and attending the episode of The Two View. You can subscribe and rate us on Apple iTunes Podcasts, Google Podcasts, and Spotify. Search for Two View Emergency if you would, and it comes right up. We get ratings. They help us climb the charts, and so that helps everyone get the Two View goodness that you have just experienced. If you like YouTube and you want to see Rob's spotless white coat, very fetching, Rob, Martha's white blouse, my blue polo, you can go to YouTube and search for Center for Medical Education. You can catch the video version of this. Don't forget our website where you can go next level on any of our topics from any of our episodes, including all the papers and sites we referred to. That's 2view.fireside.fm. A brief note before we launch into our usual people here, right? We have somebody retiring from the mothership, Colleen, and Colleen has been such a huge help to literally anybody in the CCME family. She always makes us feel like princes and princesses in our journey to give our talks live, and she makes it easy. So all we have to do is show up and sound smart or smart-ish. So Colleen, congratulations. I wish you a really exciting and full retirement life. Thank you.
Ditto, Colleen, and the special thanks to Ricky Bucata and Dave Pett, as well as Meg Dipple, for taking the reins on so many things. So thanks again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks again for sharing your time with us on the Two View. Have a good day and a great shift.
You guys want to get some shellfish?